Hey everyone, how are you all? Welcome back to my channel. Believe it or not, this is number 7 now, me trying to record the beginning of this video. I don't know why, but sometimes I just either have so much to say, that I talk crazy, or when I talk about something, I drift away to a different topic, and then I was like, what I was talking about? Where did I start? And it's crazy. Anyway. Hopefully this is going to be my last recording now, and I won't make many mistakes. And also those of you who have English as a second language will understand when you try to talk nice and clear and understandable, sometimes the things come out from your mouth that just don't make sense completely. So, and today I will try not to clap my hands, because I've noticed from my last video when I was talking too quick, trying to deliver to you all the information that I wanted to say, I started to clap my hands literally every few minutes, and I was like, when I was editing the video and I saw myself doing that, I was like, oh my god, this is so crazy. Like, I was so ashamed why I was doing that, but it was no way to actually, like, again I clapped my hand, it was no way to redo the video, and I didn't want to record a new one because the whole video was really long, although I was trying to speak quick to squeeze as much information as I could, in a short time and stuff. So yeah, control my hands, do not clap. Okay guys, oh, I'm not cutting that out. So, in today's video, some of you have asked me to share with you my experience of being in surgical and medical wards, okay? So I will be talking from perspective of being EN, because since I moved to uni to second year to continue my Bachelor of Nursing Science, I haven't done any surgical and medical clinical placements yet. My first placement was in semester 1, which is ended now, in Entry K unit, okay? And if you haven't seen that video, I will leave the link in the description box below so you guys could watch and see what I've been doing in that placement, in that unit. So yeah, so what I'm going to tell you now is only for ENs, when I used to do my diploma of enrolled nursing. But yet I should tell you, like, because I had some RN students with me at that time, they were actually from my uni as well when I was doing my diploma of enrolled nursing, and we all were doing the same things. It's just the scope of practice is only different, some of the things I as an EN, I couldn't do it, whereas my RN students, they could do it, so I could observe them and stuff. But yeah, like, the case that I'm going to mention to you now, they will be really similar to RNs and ENs, apart from scope of practice. So let's start from the surgical ward. So in your surgical ward, obviously you will have patients who come after surgery. So they will have either knee replacements, shoulder, hip, maybe some other surgeries and stuff like that, depending on the facility, what type of surgeries they provide, whether it's a public or private facility, and depending on the surgical ward. Some surgical wards would be only, for example, specializing in abdomen surgery. Some would be in limbs, like orthopedics, for example, and stuff like that. So I was dealing mostly with knees, hips, shoulders, and I think I had few carpal tunnels as well, but those were really short and person didn't need to stay in a hospital for long. But if you have like a major surgery on knees, shoulders or hips, you will stay in surgical ward for quite a while. So your shift will start as any other shift on other wards. So you will need to come in, and grab your planner, grab your handover sheet, go through the handover from the previous shift, whether it's a night shift if you're starting in the morning, or it's a morning shift if you're starting your PMs. Times would be exactly the same. Sometimes it differs from facility to facility. Some morning shifts will start 6:30, finish in 3 o'clock. Some will start 7, finish in 3:30. Some of them for night shifts will finish 10:30 or 11 o'clock. Again, depending on the facility, starting 2:30 or 3 o'clock. Okay, so that would be the same. You will have your planner, you will have your handover sheet, you can put the things and tasks that you need to do in your planner, and you will go on your shift. So the ratio of the patients to the nurses where I've been, it was 8 patients per 2 nurses. Again, it could be 2 RNs or EN and RN, okay? But it also always has to be RN, okay? Especially for medication checks like Schedule 4, Schedule 8, IVs, insulin, antibiotics if you give it as a bolus, and stuff like that. So yeah, so that was the ratio. Not as high as in Entry K unit, where I've been in my last placement. So, but yeah, in surgical ward you will find it's more intense, and you will understand now why once I start to talk more about this word. So, let's talk about OBS. I think this is the most one that would be different to other wards, because when you will have patients coming from the surgery, okay, depending on the surgery, okay, they will be or maybe on PCA. PCA is a patient-controlled analgesia. This drug, or it could be morphine, it could be oxycodone, it could be combination of two or some other medication together as well. This drug is running through IV line, okay, and the patient has a control to press the button, you know, every 5 minutes or whatever, you know, to administer themselves this drug so they could control their pain level. Okay, so when these people are on PCA, you know, especially on morphine, you know, it can suppress sometimes their respiratory rate, you know, and you have to watch their OBS, you know, you have to watch their blood pressure, respiratory rate, you know, oxygen level, you know, heart rate and stuff like that. So because of that, most of these people who are on PCA, or should I say even all of them, because I haven't seen even one that wouldn't be on 30 minutes OBS, so they will be every 30 minutes OBS, okay? So you have to check their OBS literally every 30 minutes. So what you will do, you will just leave a machine there, you know, and you will usually will have about 3 to 4 machines in your surgical ward, and you will usually have about 3, maximum 4 post-op patients. So they call it post-op when they come on PCA from the surgery, okay? Because if you have 8 patients all in total and almost half of your patients are on PCA and you have to check their OBS every 30 minutes, and you have another 4 patients who are on normal OBS, whether it could be 2 hours, 4 hours or 6 hours, you know, it becomes a little bit hard for you physically to just run everywhere, you know, even though it's 2 of you as nurses. So yeah, the maximum would be 4. Most of the time I had like 2, 3 post-op patients, you know, and trust me, when you have other tasks to do and yet you have to look after these patients and do their OBS every 30 minutes, your day goes really busy and really fast because it's literally full on. Okay, so together with OBS, this 30 minutes you will need to get the readings of the PCA machine to see how much of drug was administered, how many times the patient clicked the button. You know, you will assess pain level, you know, when you do the OBS, and then after you finish your OBS as well and pain assessment, you can do neurovascular OBS as well. So you're checking the strengths, you know, of the limbs, whether if it's for example was let's say if it was surgery in the shoulder, so you will be checking this arm and comparing it to this. You will be checking capillary refill on the end of your fingers. You will be checking sensation, you know, strengths, you know, if the person can, if it's a leg, move up and down the foot, for example, or, you know, squeeze the fingers and stuff like that. So you will find some of them would have nerve block, and it's really interesting to actually see how they're coming out from there, you know, and how the limb starts to move again, how they start to feel sensation in it, you know, and stuff like that. So you will need to do your neurovascular OBS as well and write it down together with your OBS, but in different charts. So you will have a chart for neurovascular OBS, you will have your main chart for your normal OBS, pain assessment at the back, and there as well you will have your PCA readings as well. So that is for the patients who are on post-OBS. Then you will have patients as well when they're coming out of post-OBS. There will be hourly OBS, then 2 hourly OBS, and then 4, and they go on just sort of like a normal ranges. And then you will have those who are not on PCA. They've been already, for example, on PCA and it's been over for them, and then you look after them already when they are on 4 hourly OBS or 6 hourly OBS. So you will have all ranges of hours for your OBS in this surgical ward. So it's very important to actually run your planner, because it's not like it's standard for everyone, you know, so you will have different times for each patient, literally. So it's very important and helpful to actually run your planner and put all your OBS in it. Then you will have on this ward a lot of wounds. Okay, you will have obviously your surgical wounds. Some of them will be non-touchable for up to 7, you know, or 14 days, depending on the surgery, you know, but some of them will be on vacuum dressings or vac dressings. In short, this is very interesting. When I used to be EN there, you know, as a student EN, I couldn't touch those. It was not in my scope of practice. but I could write down, you know, how much of fluid came out in a fluid balance chart, and I could see if the dressing is intact and dry, you know, and write it down, document that as well. But I've seen a few times when the nurses were changing the vacuum dressing, you know, it's really interesting to actually see. I'll try to find the picture and put it for you here on my screen so you could see what I'm talking about. So vacuum dressing is literally, it has like a small foam inside on the insertion side, you know, and it has, and then it has a vacuum, not a vacuum, it has like a plastic dressing on top, and then it's attached to a sucking thing, you know, with the motor, that it's sucking air out and make it vacuum dressing, you know, and it's really cool. And it has a drainage to it. This is where it goes in a small package. It sort of reminds you like an IDC, when people have IDC, indwelling catheter, and you know, and they have the drainage bag. So this is like it, but very like smaller in size, and you can write down how much of blood came out or other fluids and stuff like that, depending on the surgery. So yeah, so that was fun to see, and especially when someone come and change it. So yeah, and remember, it has to be an order to change those dressings, or any type of dressings. It has to be actually, especially after surgery, you need to have an order from your doctor. Okay, so yeah, because certain dressings after surgery, they need to be changed in certain times. You know, you can't just change it right away after surgery or something like that. As I said, some of them can be 10 days, 7 days, 14 days, depending on the surgery. The other experience I had, I remember I was watching a patient. He had a skin graft, and we needed to change the dressing. Oh my god, this was probably the most exciting experience, because I know what the skin graft is. You know when they take in the top layer part of your skin, if you have somewhere like a burn, or you have some sort of like a wound that you've lost the skin, and they need to replace that skin there, so they could take it from somewhere in your body. Usually it can be on your thighs, any side of your thigh or hip, you know, and they can put it for example on your shin, somewhere in your lower area of your leg. And I had a patient, he had like maybe this size, it was sort of like a rectangular shape of skin taken, and we needed to change his dressing. And when we took the dressing off, I could see that the layer of the skin is off. You know, that was really fascinating to watch. Like, I'm not afraid of blood or anything like that. I can watch a surgery all right. Like, I'm only afraid of big needles for epidural. And if you watch my other video when I shared with you my experience of going to operating theater, I said there that I couldn't watch epidural, needle going into spine and coming out and taking spinal fluid out, and I couldn't watch it. That's the only thing that I found that I feel lightheaded, but everything else I'm fine. So this is why I'm saying, like, it was fascinating for me to watch, because I learn by watching something like that, you know. And it's, I don't know, I guess it's funny and maybe some way bad to say, but when you're a student, you feel happy when you have opportunities, you know, like when you have big wounds, you know, or someone bleed or something, or I don't know, or you have like chest pain episodes. I know it's not fun for the patients, obviously, because nobody of them would want to be in such situation. This is why I'm saying, like, it's funny and a bit maybe bad to say that, but when you are as a student, like, you're looking for opportunities like that, because if you see something like that, you learn from it, you know what I mean? Because if your shift just goes like plain and you don't have any situation that you can relate to from your studies in a class when it comes to chest pain, you know, or complex wound dressing change, you know, and stuff like that, like, how can you learn, you know what I mean? So yeah, I know it's like, maybe it's a bit selfish for us as students to say that, you know, but I'm sure you all been there like me, you know, and when you have something exciting coming along, you're like, oh, okay, that's cool. Like, obviously in the back of your mind, you know, you feel bad for the person and you're trying to help as much as you can, but also when the situations come like this, you can actually learn. And yeah, this is good experience for us. So next, you will have a lot of IDCs. So as EN, you won't be able to insert IDC if you need to, but in surgical ward mainly you actually taking them out, because they already come with IDC because it's been inserted before, prior to surgery, you know, and they come out from the operating theater and pack you, you know, recovery room to surgical wards having IDC inside, and it will stay for maybe a day or two, and then it will be taken out. So as EN, you can't insert it, but you can take it out. As RN, you can insert it and take it out and remove it. So as EN, I did not even practice taking it out, to be honest. I was just watching. And once you take the IDC out, okay, you will ask your patient to do trial of void. It means going to do number 1 or P, to go to toilet. And then after that, you have to do a bladder scan and see how much your fluid is retaining inside, if any, okay? And you will do this 2 times, or some facilities practice even 3 times, depending on the facility. Okay, so me as EN, I was able to do bladder scanner, and I've been taught how to do it and how to find a bladder on a monitor, you know, and then start the scan and how to scan. Different machines scan differently, you know, they have sort of like different techniques of how to scan it. And now as RN, I've been doing bladder scanner as well. So I would say, like, for ENs and RNs, it's pretty much the same. You will have opportunity to use bladder scanner. You know, if your nurse doesn't give you that opportunity, you may ask, just ask, can I try? Once you watch her, and then on the next patient, you can try and just ask, can I try? It's very simple, but you need to learn that because it's useful and it's fun. Next, you will have obviously medication administration, but here in surgical ward, you will have medication administration through IVs, okay, through boluses, through push, like for example your antibiotics, and you will be reconstituting antibiotics and other medications as well. You may have patient who has PEG line, okay, this is for those who could not swallow, you know, or they are paralyzed, you know, for example. So you will have PEG line. It's pretty much like a tube going through your abdomen wall right through the stomach to the stomach, and you can administer food. It's going to be like a food, it will look like a smoothie. It comes already ready in bottles or containers, and you withdraw it in a big syringe and then you push it through the line. So you will have food being administered through PEGs, medication, fluids. Yeah, that's pretty much it. To get some nutrients, you know, and some like sustagens and stuff, you know, it's different type of drinks. So you will have those. So you can do medication like that. You will have medication administered by IM and subcuts. You will have lots of subcuts. You will have insulin to do as subcut. You will have heparin to do as subcut, you know, because a lot of patients will have heparin as a prevention of blood clots, because obviously after surgery and during the surgery you're not moving your limbs, you know, and after surgery you're just staying in bed, you know, for some time. They will have all TADs and SCADs on. This is literally you know, when you have like your pressure stockings or tubey grips, so that's your TADs and SCADs. And then you will have on the top, you will have so you have TAD stocking and then SCADs. I don't know how to explain it. I'll try to find the picture for you and put it here in the video. Hopefully I will try to Google it up. So it's like big, sort of like a sleeve. You put it on top of your leg, on the top of that compressor stocking, and then it's connected to the motor in the bed, and it's pumping up the air in certain pressure level, and it's like deflating and inflating, you know, on your legs. So that's pretty much like just pushing your blood up, you know, and letting it to move, so it wouldn't be staying down, you know, in your legs. So so yeah, so anticoagulants and TADs and SCADs, they work sort of like in balance as well. And what else in terms of medication? Obviously you will have your orals, you will have eye drops, you will have sprays. What else? Yeah, I think that's it. So you will have lots of different medications, okay? My favorite one is to administer antibiotics via push. So you will use your IV line and the cannula that you will have in your patient's arm, okay? You will need to reconstitute the medication and then administer it as a push. I remember we as EN students, we used to practice a lot in labs to do push. Okay, so that was fun, and obviously you have to do this with RN, you know, in drug room. So you will have your medications if it's a morning shift, you have most of them you will have in the morning, then some of them you will have at 12 o'clock, then you will have lots of your Panadols at 2 o'clock, you know, and then you will have lots of PRNs like endones, you know, codeine and stuff like that, depending on the order for each patient. What else? You will have your BGLs, okay, as probably in any ward, because unfortunately a lot of people have diabetes. Some of them will be on standard check pre-meals 4 times a day, and the last time would be before bedtime. Some will have BD morning and night, so you will need to check that. And if some of them on insulin, you will be practicing your subcuts as well, and you will be practicing, you know, using your insulin orders when they are on a regular order. And also if they have a sliding scale, you can practice how you can use the sliding scale and how can you add those two. If you're interested about insulin and how I explained it from my experience from the Interim Care Unit, please go to that link that I provided in description box below about my experience in Interim Care Unit, and I explained there about sliding scale and insulin and how does it work, how you calculate it and stuff like that. So you will do that. And there is something I wanted to tell you actually. Just be careful, because you will have quite a lot of patients on anticoagulants. When you prick their finger, just make sure to, you know, put a piece of tissue or cotton or whatever will be in your BGL kit, you know, and make sure before you leave the patient that the blood stopped, okay? Because it did happen to me once. I did not know that the patient was, and that was actually medical ward, not surgical ward, it was a medical ward. I did not know that my patient, that person was on anticoagulants, and I've done BGL. I put the, you know, tissue, you know, and I said to her to hold it, you know, and then I went to do my other BGLs, you know, and I was getting to get ready for medication administration as well. And when I was passing back through the room of the patient, I found that the patient put the arm down, you know, and just sitting, and the blood is leaking on the floor. It was just a small puddle on the floor, but I was like, I freaked out. I was like, oh my god, like, I didn't know that the patient was on anticoagulants, and also that patient wasn't my focus patient. Sometimes you will have in a ward that, for example, you will have your 8 patients that you and your body nurse looking after, and the third nurse as well. So you will have 2 nurses and you as a student, and then you will have other nurses obviously looking after another 8 patients, because the whole ward can have 20 beds, you know. So sometimes what the nurses do when they are really busy with medications or other cares, they will tell you, okay, we have due now this and this bed for BGLs, would you like to go and do it, you know? And it's okay, we all work as a team. Sometimes you will go and do it. So this was one of those patients. I didn't know much about this patient. Nobody told me that that patient was on anticoagulants. So when I've done that patient's BGL, you know, yeah, some blood leaked, you know, and I didn't know about it. So I needed to report it to RN when that happened, you know, and I put again a piece of cotton to her finger, you know, and yeah, and it was fine. Like, it was a nothing measure, but you just have to keep this in mind, you know, when someone on blood thinners. You will experience as well removal of cannulas, okay? So when someone will be off IV, you know, whether it was normal saline or glucose or medication or whatever it is, you will be asked to remove the cannula, okay? Or they may leave the cannula for some time if that person is still on antibiotics via push, okay? So it depending on the patient, but removal of the cannulas is a great experience as well for you to try, and this can be done by ENs and RNs, okay? Next, sometimes depending on situations, like for example, if you will have chest pains, you know, and stuff like that, you will be doing ECGs, okay? Surgical wards and medical wards, they do have medicals. The professional team will come and help in those situations, but yes, you will be doing sometimes ECGs as well, you know, while you're waiting or while they come in and stuff like that, or if the doctor orders. So you will have practice of doing ECGs, okay? Obviously in both wards, in medical and surgical, you will be helping with IDLs to the patients. So it could be assistance with showering, toileting, changing clothes, you know, walking, feeding, transferring and stuff like that, okay? Or even sometimes changing channel on the TV, you know, and like really simple things. So yeah, so both of these wards you will be helping like that. Of course you will have ANs and you will have wardies as in any hospital to help you as well, because in the morning you as RN or EN, you will be busy doing medications as well, and you have a lot of things to do, you know, so not always you can help showers or toileting or changing or bed washing to all your patients. This is why they have wardies, you know, to help with transfers. They have ANs who can shower one or two or three of the patients that you're looking after and just take a little bit load out of you. You will be doing care plans. Care plans will be done. Some of the facilities do it every shift, some of the facilities do it once a day only. Okay, so it depends on the facility. In care plan you will be just updating mobility, because most of the patients actually after surgeries, they will be assessed by the physio at some point and will be what is that word, advised or to move. Okay, so they need to move. You can't stay in bed most of the time, like, because it's prevention of blood clots. You have to also bring back your mobility to the body. You are on a pain relief, so the pain is not that bad for you to sort of like distract you or stop you from moving. So all of that is controlled. All what you need to do is just try to start to move your body back again. So the physio will come to the patients and they will assess the patients, you know, and some of them can start to get off the bed, you know, to start to get out of the bed, maybe using four-wheelie walk or maybe using crutches, you know, and stuff like that. So it depending on the facilities, on the physio's assessment, the person will be in either one of those mobility equipment. So you may be helping people to move, you know, using those equipments. And when you do a care plan in the end of your shift or in the end of the day, you have to write down whether that person was assessed again or reassessed by the physio and now maybe changed from, let's say, crutches to a wheelie walker, or from wheelie walker to a one crutch only, you know, or maybe person can now walk by themselves but stand by assist, you know, and stuff like that. So you have to mention all of that. What else could be changed? Sometimes in your care plan could be changed, you know, amount and the frequency of OBS. For example, if the person was on 2 hourly OBS, you know, and that period was finished, the person can go now on 4 hourly or 6 hourly OBS. So you have to change that as well, so the next shift could know. If the IDC was removed or cannula was removed, you have to mention that as well. You will have admissions and discharges. Most of the time you will have admissions obviously from the operating theater of the same facility. Okay, so usually people will come from PACU, which is your recovery room after theater, and PACU will give all the paperwork and stuff like that, which medication, what type of medications patient had after surgery, you know, and OBS, last OBS in PACU and stuff like that. So you will have that paper coming, and then you will need to fill in your admission pack as well, which is just a bunch of different forms, okay, of documents and stuff that you will need to fill in and put it in a patient's file, and some of them will go to the blue folder of the patient. Then in this ward you will be also doing discharges. Discharges could be right to home depending on the surgery, or could be moving back to, not back, but moving further into medical ward, you know, for the further cares, or it could be patient could be moved to rehab, okay, in rehabilitation unit, where they will be working more with physios, you know, to mobilize more further and better, you know, and stand on their feet as before. What else? You may have tracheostomy, suctioning, and care in general. So if somebody has a tracheostomy tube, you will need to suction it sometimes, okay? Some people can have mucus in there gathering in trachea and also in lower airways, and they will need suctioning either pre-meals or pre-medication or pre-inhaler, you know, medications and stuff like that. So you as EN won't be able to suction it, but if you will be RN, you can do the suctioning, you know, under supervision of RN, of another RN nurse. So that is fun. It's interesting to watch. I haven't done it myself. So far I've been only watching because I didn't have that opportunity when I used to be not not when I used to be EN. When I used to be EN, I couldn't do it. I didn't have that opportunity when I become RN student because I haven't been sent to surgical wards yet. Also, you will have weight charts to check patients' weight. Some of them will be on daily weight, some of them will be second daily, depending. You will have your fluid balance chart or food chart. Okay, so you will need to document intake of fluids and output of fluids indoors, and the food chart, how much patient adds in the morning, you know, lunch and dinner. Those ones are not really often, but you may have food chart. But fluid balance chart is quite a frequent one. Okay, and I think that would be it. I think I mentioned all the cares and all the clinicals that you may have. Sometimes you may have palliative patients in your medical ward, and you will need to reposition them. Okay, because they will be on pressure care repositioning regime, so you can do that. And you will have a form for it, for repositioning, so the other shift could know when the last time the patient was repositioned, and either that patient was repositioned frequently, like every 3 to 4 hours or 2 to 4 hours. So I think this is all what I wanted to mention in this video regarding your clinical tasks when you do your surgical and medical placements. So medical will be very similar as well. You will still do your OBS in there, you will help with ADLs. You know, for the patients, you will administer medications. You may still have IVs as well in your medical ward. You will have your subcuts, IMs, still going on with BGLs and stuff, you know. But you will find that your patients in medical ward are more mobilized, you know, apart from some of them who are, for example, elderly in really like late age, you know, and they're not really mobile. But yeah, but most of the people, if you've been in surgical in the same facility and then you had a week or two in medical, you may actually find the same patients moving into medical ward, so you will see them there again. Yeah, so these two wards very similar in cares, apart that PCA is not going to be in medical. Okay, patient controlled analgesia is not going to be present in medical. But yeah, everything else will be pretty much the same in terms of your cares. So if you have any questions, I hope this video helped you. I try to remember and bring to you everything that I know about this ward and what I've done when I used to be a student. But again, just remember that on each of your placements, you may have different situations, you may have different patients. This is just my perspective and what I've witnessed, you know, and experienced during my placement. Of course, you may have different cares, you may have some extreme situations when you will learn something new and different, you know, during your placements, and that will be just your experience. It doesn't mean that it will happen every day. But yeah, so I hope this video was helpful for you guys. If you have more questions about it, or maybe something I forgot to mention, leave it in the description box below and I will be happy to answer. I'll see you in my next video. Bye!